Good afternoon, ladies and gentlemen. So, welcome to the January meeting of this program, Periphery to the Fore. The Periphery to the Fore is something that the Ceylon College of Physicians have introduced over the last couple of years to showcase and get our physicians and other specialists working in the peripheries to share their experience and their knowledge with others on an important area related to the clinical practice. So in today, we have two lectures. One on snakebite envenoming, insight from peripheral healthcare settings by Dr. E.W. Rohitha Amara Witharana. Rohitha had been a personal friend. He is MBBS from Peradeniya, MD, Colombo, FCCP, Consultant Physician, Base Hospital, Gampola. Over to you, Rohitha.
Thank you, Professor Kadunandu, for your kind words of introduction. And good afternoon, everybody. First of all, I would like to thank President and the Council of Ceylon College of Physicians for inviting me and giving me this valuable opportunity to talk to you on snakebite envenoming. Insight from peripheral healthcare setting. No conflicts of interest to declare for this presentation. And objectives of today's presentation, snakebite envenoming. I discussed first 4 case scenarios from peripheral healthcare setting where I work. The latter part of the presentation is key information on snake identification, clinical evaluation, and management of snakebite envenoming. As we have limited time, 30 minutes for the presentation, mostly I discuss the clinical scenarios. This is the first case, severe envenoming after Russell's viper bite. Our patient was 39-year-old lady from Kolongoda, a rural area, was bitten by a snake while she was collecting vegetable to prepare her lunch and admitted to the base hospital, Mahiyangane. She was collapsed in 30 minutes, very short period after the incident, and patient was admitted to our ETU. Patient was resuscitated. She had conjunctival, periorbital, and facial edema, indicating increased vascular permeability. With severe circulatory failure, her blood pressure was unrecordable, tachycardic, and ECG shows severe sinus tachycardia and developed neurotoxicity and nephrotoxicity, reduced urine output and very dark color urine after that, and incoagulable blood with prolonged PTINR and prolonged 20 WBCT. However, the patient succumbed to the illness and died after a few hours despite maximum medical care. She was on full supportive treatment, including inotropes and ventilatory support. Patient passed away. This is the snake, offending snake brought by the relatives. I am sure everybody in this audience can easily identify what is the offending snake. The triangular head and short tail, and you can see 3 rows of brownish patches on the body. So this is Russell's viper. And this is the ventral surface of the snake. You can see abdomen is abnormally distended. So it could be due to swallowed prey inside the abdomen or gravid uterus or any other pathology. So we did dissection of the specimen and took this partially digested mouse out from the abdomen. I would like to thank one of my house officer, Dr. Chintaka Pitikalarajji. He took all photographs and did this resection as well. So I would like to thank him. And this is the elbow of the patient. You can see there is bleeding from the puncture site. So we went ahead and did autopsy. And this is the bite site. And you can see there is bleeding and clot at the site of the bite site. And these are the macroscopic appearance of major organs, heart, brain, and kidneys. All major organs are macroscopically normal. Then we did histological examination, and you can see on the right-hand side top two histological pictures of liver and kidney. Both liver and kidney histologically normal. So the other histological specimen picture is lung. You can see lungs are heavily infiltrated with macrophage. So I would like to thank our JMO who did the autopsy and send me all those photos, Dr. Taranga, for this presentation. And so we discussed with the pathologist and the consultant JMO, and they suggested, because we have not seen much macroscopic or microscopic changes, because the patient passed away within few hours and he developed severe hypertension just after the incident, and probably there is no adequate time for the development of macroscopic and microscopic changes. So sudden death is a potential complication of snakebite envenoming. Why this patient suddenly developed hypotension and collapse? So let me to discuss pathophysiology of hypotension and shock after snakebite envenoming. So it could be massive hemorrhage. You know, a lot of toxic substances are there in snake venom, which can cause incoagulable blood and causing bleeding. So there should be external bleeding or even massive bleeding inside the body, especially bleeding into the gastrointestinal system. But here our patient has we have noted only bleeding from the puncture site, and we couldn't see any massive bleeding inside the abdomen. Also, it could be due to vasodilatation, especially vasodilatation of splanchnic vessels that can cause hypotension. And also, there are toxins in the snake venom which can directly damage to the myocardium, and so those are cardiotoxic chemicals. Sometimes you can see ECG changes or epicardial or endocardial hemorrhages and cardiac myonecrosis after snake bite. That is mostly due to the direct toxic effects of the venom, but we didn't see any changes of our patient. So other possible cause of hypertension and cardiovascular collapse is due to primary anaphylaxis induced by the venom itself. So that is also a possibility here. And also leaking of plasma can cause hypertension. The venom of Russell's viper, lot of toxic substances are there, can increase in vascular permeability, resulting pulmonary edema, serous effusion, and hypotension. So those are the possible pathophysiological explanation why a patient develops a sudden collapse after snake bite. So our patient of also one of the victim with hypotension and cardiovascular shock after Russell's viper envenoming. Let me discuss my second case scenario, a venomous snake bite, no envenoming site. That is a case of dry bite. Our patient was a 15-year schoolboy from Diula Palace, again far away from the rural area, somewhere there in Mahayangane, was bitten by a crate at 7:45 p.m. while he was sitting on a chair. Patient was totally asymptomatic and admitted to our hospital, base hospital Mahayangane, for further evaluation. And physical examination was unremarkable, and we discharged patient after 48-hour observation. Again, this audience can easily identify offending snake brought by the relatives. The oval-shaped head, vertebrae are enlarged, black dorsum with paired white rings, and also subcords are uniserial. So it is very clear this is the snake, common crate or the Indian crate. So victims of deadly venomous snake bite can present without symptoms and signs of envenoming. So AVS should be commenced if indicated only. So we can't use antivenom for each and every patient. So we have to observe patient and see whether there is indication, especially systemic envenoming. And let me talk a few words about dry bite. The quantity of venom injected is very variable depending on the species and size of the snake, and also the mechanical efficiency of the bite. So there, you all know there is a compressor muscle associated with venom gland of the snake, and if it want to inject venom, it should contract this compressor muscle and inject venom into the victim. So that maybe depends. Sometimes the snake can totally empty the venom gland using this compressor muscle. Sometimes maybe partially injected. So that is the possible explanation for the dry bite. And also, snake may inject 40% of the venom gland contents in the first bite, which was well documented. And also, there are some studies showing about 50% of rhesus viper, 30% of cobra, and 5 to 10% of saw scale white bite do not result in any symptoms or signs of envenoming. It could be a dry bite. And also, just after the snake used the venom to kill the prey, the venom gland may be empty. So after that, there is no venom to inject. So it could be a dry bite. So this is the whatever all guidelines recommend. The most important decision in managing snake bite victim is whether or not they need antivenom. So antivenom is very harmful. So we have to carefully decide whether this particular patient needs antivenom or not. And this is the third case, severe anaphylaxis after antivenom serum treatment. Our patient was 28-year-old gentleman from Hettipola having bronchial asthma, presented to our hospital after snake bite envenoming. He developed severe neurotoxicity and incoagulable blood with prolonged 20 WBCT. So it is a clear case of rhesus viper bite and envenoming. So we started AVS and he developed severe anaphylaxis. Blood pressure was very low and patient was dyspneic, and it is a very typical case of severe anaphylaxis. With IM adrenaline, IV Piriton, IV hydrocortisone, IV fluids and salbutamol nebulization, he recovered fully. So we restarted AVS infusion. Then, however, we were unable to continue AVS as the patient got anaphylaxis repeatedly. When we start antivenom, patient developed anaphylaxis. So it is very difficult case. Patient was severely envenomed and unable to continue antivenom. So patient is, so how can you manage this case? So we discussed with several experts on this subject, and we observe patient. If need, ready for the ventilation, and all inotrope supports also we keep ready. And then we discuss with several experts, and final decision was we have to give 400 milligram of IV hydrocortisone and observe few hours, because it takes 6 hours to work hydrocortisone. Then we gave, actually already at that time patient was given 400 milligram of hydrocortisone because he developed anaphylaxis repeatedly. So after few hours we start ABS, and patient developed no any signs of allergy or even no anaphylaxis, and we completed antivenom. Also, another dose of ABS was repeated again after 6 hours as 20 WBCT was prolonged. The patient made a complete recovery with no complications. So this is difficult case because patient developed severe anaphylaxis repeatedly for the antivenom. But after 6 hours of hydrocortisone treatment, we have seen no single signs of allergy for the antivenom. So AVS can be restart 6 hours after IV hydrocortisone if victim develops severe anaphylaxis to AVS repeatedly. Let me to talk few words about antivenom reactions. A substantial proportion of patients develop reactions either early or late after being given antivenom. In Sri Lanka, there are studies Professor Harirani and others did, and in Sri Lanka, Indian polyvalent antivenom incur reactions in as many as 81% of recipients, and severe reactions in as many as 43%. So severe anaphylaxis was well reported after this the Indian polyvalent antivenom treatment. And life-threatening anaphylaxis have probably been underreported, as death after snakebite is usually attributed to the venom, and patients may not be monitored carefully after treatment. So this is very common thing happening in especially most of the peripheral hospitals of the Southeast Asia, and well said by the WHO guidelines. So prevention of antivenom reaction, how can you prevent? So our Sri Lankan guidelines, also SLMA guidelines also clearly say, so prophylactic use of adrenaline is effective method to prevent anaphylactic reactions for AVs. So compare with placebo, adrenaline significantly reduced severe reactions to antivenom by 43% at 1 hour. So it was documented. And for adults with no comorbidities, and dose of adrenaline is 0.25 milligrams subcutaneously just before the antivenom treatment. So that could be useful. This case highlight our patient, we have given actually this subcutaneous adrenaline also before antivenom therapy, but patient developed severe anaphylaxis. So this case highlight, it could be useful that IV hydrocortisone is working in 6 hours and prevent severe anaphylactic reactions. Let me to discuss the last case, the case number 4, severe local envenoming after cobra bite. Our patient was 28-year-old lady, was bitten by a cobra when she was walking in tea plantation at Galatha is somewhere there, rural area close to Gampola hospital. And person was admitted to our hospital where I work now. And she had severe pain and developed bluish discoloration and later gangrene, and no systemic envenoming noted. AVS was given and surgical debridement was done. Patient has no systemic envenoming, but there is, guideline clearly say cobra bite patient, if you have, we have to give antivenom for the local reaction. So this is the foot of our patient half an hour after the incident. You can say bite marks with bluish discoloration. This is the next day, 24 hours after the incident. You can see blisters and more blackish discoloration, and you can see forming gangrenous tissue. And this is fourth day of the incident. You can see there was very big area of gangrenous tissue, and we did wound debridement with the surgical tip help us. And this is few days after the incident, day 4. And this is few days back patient presented, and he is waiting for the skin graft, and there is well-developed granulomatous tissues, granulation tissues. So patient recovered, but you know that the cobra bite can cause severe local envenoming. So let me talk few words about local envenoming. So swelling and bruising is very common. You know, a lot of patients come with swelling and bruising after snake bite. That is probably due to increased vascular permeability and bleeding. A lot of toxic substances are there in snake venom, especially venom endopeptidase, metalloproteinases, polypeptide toxins, phospholipases, and endogenous autocoids, which can cause the increased vascular permeability and also swelling. And also, local tissue necrosis is a direct effect of venom, snake venom. So myotoxins and cytotoxins can cause the necrosis of the local tissue. And also, you know, snake venom can cause thrombosis, and distal area can become gangrenous. And AVS should be administered for cobra bite with local envenoming. We don't want to wait for the systemic envenoming. And yeah. So I already spent 20 minutes for this presentation. I have 10 minutes for my presentation. So reducing the risk of snake bites, just consider whatever the case I discussed, cobra bite case. The patient was bitten while she was working in tea plantation. So you know that tea plantations, the tea bushes are joined together, and nobody can see what is happening on the ground. So a lot of people are working in tea plantation. And so this is the incident we reported. And with the cobra bite, she was bitten by a cobra because she has not seen. So WHO clearly say raising community awareness about prevention of snake bite is the most effective strategy for reducing snake bite morbidity and mortality. So prevention is most important. So how can you prevent this sort of bites? That's what WHO highlight this. So at the national level, even it's a common thing in our country, this the tea plantation, and they work, we can't see what is happening on the ground. So we have to advise those people to use appropriate shoes, boots to prevent the snake bite. So this sort of simple things we have to address nationally. So a lot of things we have to address for the prevention of snake bite. So this is the second part of my presentation. I have a few minutes. So snake bite envenoming, I will briefly go through these slides. So in the world, 2,500, 3,000 snakes are reported. About 500 snakes are venomous. In Sri Lanka, we have 96 species, of them 10 venomous. Africa, 40 snakes, 30 venomous. Every year, 5.4 million people were bitten by snakes. In Sri Lanka, we have 40,000 bites per year. Of them, nearly 100 die. Snake bite envenoming is a neglected tropical disease. WHO says, comments, and WHO said that 2017. So you can see this picture of Oxford Textbook of Medicine, first volume we used during our registrar periods. And this book, you can see the back page of the first volume. The picture is the dreaded teeth polanga of Sri Lanka. So you know the editor of this book is Professor Fore. Everybody know he is the world author of Snakebite Envenoming because he did studies extensively on snake bite all over the world and published thousands of papers. However, they decide to put this picture, the treated Titpolaga of Sri Lanka, process viper, for the back page of the Oxford textbook of medicine. So you can understand the gravity of snake bite in this country and the severity of the poisoning, also the envenoming of after snake bite envenoming. So that's why I put this picture. And so let me to discuss very briefly what are the poisonous snake or venomous snake in Sri Lanka. So historically, we classified the snakes as severely venomous snake, moderately venomous, mildly venomous, or non-venomous snake. So according to the WHO classification, now this classification is different. So basically, we classified snakes, medically important snakes and medically not important snake. So you can see this very clearly. Guidelines are there, SLMA guidelines. You can see the classification. So according to this classification, we have 10 species of snake which consider as medically important snake. So namely cobra, common krait, Sri Lankan krait, Russell's viper, 3 species of hump-nosed viper. So the Merum's hump-nosed viper, lowland hump-nosed viper, and Sri Lankan hump-nosed viper. And also green pit viper, also considered as medically important snake, and also saw-scale viper, and finally Sri Lankan keelback or blossom krait. So recently we have seen a few cases, especially one case published after bitten by this snake and developed severe envenoming. So after that, that snake also considered as the medically important snake in this country. So out of these 10 species, 5 species are endemic to Sri Lanka. So we have no extensive studies on this subject because you are using the studies from other countries, but if it is endemic species and the venom content, the clinical epidemiological findings, we have not well studied. Then quickly I will go through this slide. So identification of cobra, you know that, very simple, oval head. Then subcaudals are divided. There is expansible hood with the spectacle marked dorsally and ventrally 2 black spots. So that is cobra. And then not difficult. Identification of krait also not difficult. You know, vertebrals are enlarged, subcaudals are not divided. Uniserial subcaudals. 2 species we have. Common krait, you can see white paired rings on the black dorsum. And the Sri Lankan krait is, you can see the same, the white single white bands. So that is Sri Lankan krait. So let me quickly go through these slides. True vipers, very important, because true vipers, if you see carefully the head, all scales are very small. So if you see triangular shape head with the short tail, and this characteristic pathognomonic marker on the head, the bird's foot mark, that is saw scale viper. This is Russell's viper. I already discussed characteristic features. And then pit vipers. We have 2 groups of pit vipers. The hump-nosed viper and green pit viper. Green pit viper is endemic. And if your snake, the patient bitten by a snake, snake's color is brown, head covered with large scale, hump at the tip of the snout, 2 rows of triangular blotches either side of the midline, that is hump-nosed viper. So you can see this enlarged, large scales on the head. And also we have 3 species, Hypnale separate, Nepa, Hypnale, and Hypnale Sara, 3 species. And also I just say the singular term for the Hypnale species is called Punakatua. You know the meaning of that, because the bite site is become gangrenous and there are blister formations. So we use the term Punakatua. And other term is the Polontelissa. So when we do some publication, they ask what is the meaning of Polontelissa, then we search, and anybody know the Polontelissa mean Tola issi. So then you can see the hump nose. So that simple term is compatible with the explanation. So green pit viper, I have no time to discuss. So it's a green color one. And give me 1 more minute to discuss. This is important slide. So Sri Lankan blossom clade, Sri Lankan keelback. This is the case latest species considered as medically important. The 33-year-old healthy biologist was bitten by the snake while he was handling live snake for the photography. He developed severe headache, photophobia, syncope, hematemesis, bleeding from the puncture site. Also, he has the elevated 20 WBCT as well. So, patient was treated with FFP. And you can see the picture. So, this case published as first reported case of systemic envenoming by Sri Lankan keelback. So, this snake considered as medically important snake after that. So non-venomous snakes, I have no time to describe with the physical signs. And also let me to say, this is a Mapila or cat snake. You can see like a very brown color with the black patches are there. Sometimes like the hump nose, but there is no hump. But if you see carefully, the head, there is enlarged vertebrae, not the vertebrae, enlarged head scales. And these are very elongated snakes. So that is cat snake. And so the Ahatulla and the flying snake. And this is Katakalua, very frequently presented to Mahayangana. And when that species open mouth, you can see blackish mouth. So that is called Katakalua or trinket snake. Wolf snake, you all know. So I skipped few slides here. So 20-minute WBCT, you have to know how to do it. Very important for the management of patient is peripheral healthcare setting. And first aids, you all know this. And we use polyvalent antivenom. So 3 important point I have to highlight. Should be commenced as soon as possible following the detection of systemic envenoming. Antivenom should not be administered for local envenoming except cobra bite. And it is never too late to give antivenom provided the indications are present. Very important 3 statements. Then supportive therapy. The prevention of snake bite, avoid snake entering to the houses, use a light and wear shoes, clear heaps or rubbish, keep grass short, and listen to the wild animal or domestic animals. And let me to summarize my presentation. So snakebite envenoming causes substantial morbidity and is a neglected tropical disease in Sri Lanka. Snakebite envenoming is an important health issue that drives research focused on identifying new clinical features, improving diagnosis, and understanding epidemiological trends to enhance prevention and treatment strategy. Snake identification is important for the evaluation and management of envenoming, and raising community awareness about prevention of snake bite is the most effective strategy for reducing snake bite morbidity and mortality. And these are references. And thank you. So this is the Sorapara of my Yangane, but the surrounding area is full of snakes. Thank you.
Oh, that very useful practical lecture. Any questions?
Thank you for the very interesting presentation. I have a question regarding the third case. That is the patient who developed recurrent anaphylaxis. So in such a situation, did you consider plasmapheresis as a treatment strategy because it has been recognized as a possible treatment for venom-induced consumptive coagulopathy? But here in this patient, the treatment is antivenom, but that you can't give it. So plasmapheresis would have been any useful?
I think plasmapheresis has no place for the, if I'm wrong, somebody can correct. So basically, no for this particular patient because he developed anaphylaxis in the night around 10 p.m. and we need very quick treatment and reassure the patient and we have to restart antivenom. So plasmapheresis, as you say, we can use for the MAHA and other complications developed by especially hump nose viper bite. And I think we can't use plasmapheresis for that particular case.
This harmless viper bites, antivenom should not be given.
Mm.
Have you come across patients who's mistaken, not wrongly given antivenom and develop anaphylaxis when the snake is a hump nose?
Yes, of course, that's a very good question, and we know that not only the hump nose and also green pit viper. We have done 2 studies when I work in the Niyaya hospital and already published in Toxicon. And the hump nose as well as green pit viper can cause bleeding manifestation. So that's why snake identification is very important for the colleagues. Everybody should know, because sometimes patient bring his specimen and not identify it and discard the case and start antivenom. So there is no indication for antivenom for the hump nose viper and the green pit viper. So both species can cause prolonged total-die incoagulable plaque. So there is no indication for antivenom. I totally agree with you. A lot of cases I have seen, given antivenom, there is no indication for the bleeding.
Yeah. Any other questions? There's a question on the chat. There's a question on the group chat. It's regarding your experience on hump nose viper and plasmapheresis in hump nose viper. Somebody asked it. So what is your experience with hump nose viper bite and plasmapheresis?
Actually, I personally have not done plasmapheresis for the hump nose viper bite, but I have seen some articles. The hump nose viper bite patient can develop MAHA, and plasmapheresis is useful.